When an older adult leaves a hospital or rehab facility, we often say, discharge completed. But for that patient and their family, the real work is just beginning, and too often it doesn't go well. In this video, we're going to use a simple reflection model. What? So what? Now what? To look at the 5 biggest obstacles to a safe transfer home, what they cause, and what we can actually do about them. What? The 5 top obstacles. Obstacle 1. Fragmented communication and handoffs. First, fragmented communication. Older adults move from hospital to rehab to home care to primary care, with different teams, different systems, and different stories. Discharge summaries are late or incomplete, families get mixed messages, and no one is clearly quarterbacking the plan once the person is home. Obstacle 2. Rushed task-oriented discharge planning. Second, rushed discharge planning. Discharge is treated like a single event. Here are your papers. You're all set. Instead of a process that starts on day 1 of the stay. Families are rarely true partners in decisions or teaching. Obstacle 3. Limited capacity and support at home. Third, limited support at home. We send people home with new care needs, into houses that may not be safe or set up for mobility, with families who are juggling work, distance, finances, and sometimes their own health problems. Obstacle 4. Medical and medication complexity. Fourth, medical and medication complexity. Most hospitalized older adults live with multiple chronic conditions and long medication lists that change during every admission. Keeping one accurate, up-to-date list is hard, and small errors can have big consequences. Obstacle 5. Cognitive and health literacy challenges. Fifth, cognitive impairment and low health literacy. Many older adults have dementia or mild cognitive impairment, or they simply don't speak medical. They and their families may be too overwhelmed or intimidated to admit they don't understand the plan. That's the what. So what? Why these obstacles matter. So what does all this actually lead to? 1. More readmissions and emergency visits. First, these obstacles drive avoidable readmissions. Studies show that poor transitions and weak follow-up are tightly linked to 30-day readmission and ED use. When instructions are unclear, symptoms are missed until they're dangerous. 2. Medication errors and preventable harm. Second, they cause medication errors and preventable harm. When medication lists don't match across settings and families are left to guess, we see duplicated drugs, missed doses, and dangerous interactions, especially in older adults with polypharmacy. 3. Caregiver overload and burnout. Third, these obstacles create caregiver overload. Families are suddenly responsible for wound care, mobility, complex meds, and behavior changes. Often with minimal training and no backup plan, they feel set up to fail. 4. Loss of trust and engagement. Fourth, chaos at transitions erodes trust. When families feel abandoned at the front door, they're less likely to follow recommendations or seek help early the next time there's a problem. 5. System waste and deepening inequity. And finally, there's system-level waste and inequity. Revolving door admissions consume resources without improving quality of life, and the worst outcomes fall on those with the least support. That's the so what. This isn't just inconvenient. It's unsafe, exhausting, and unfair. Now what? What we can do differently. So now what? What would it look like to respond on purpose? Let's go back through those 5 obstacles, this time with specific actions. 1. Fixing fragmented communication. For communication, we can commit to a single reconciled plan and 1 medication list. That means timely, complete discharge summaries sent to primary care and key specialists. A structured post-discharge follow-up within 7 to 14 days to reconcile meds and align plans. A clear point of contact for families, a nurse, care manager, or practice line they can call when something doesn't add up. 2. Turning discharge into a process, not an event. To fight rushed planning, we start discharge at admission. We identify the primary caregiver early, include them in rounds and care conferences, and use tools like the Ideal Discharge Framework to structure teaching and questions. 3. Building realistic support at home. To address limited support, we stop asking, "Can you manage this?" in a yes/no way. Instead, we explore, what does home really look like? who will be there, and when. Then we match the plan to reality, with home health, in-home care, community services, and simple home safety changes. 4. Tackling medical and medication complexity. For complexity, we treat medication reconciliation as a must-do safety practice. Each transition is a chance to simplify regimens, deprescribe where appropriate, and give families a clear, written schedule they can actually follow. 5. Supporting cognitive and health literacy challenges, we design teaching for the real person in front of us. Short, plain language explanations. Teach back instead of, "Do you understand?" Hands-on practice for key skills. And always, including the person who will truly be making decisions. The what, so what. Now, what model was created as a reflection tool, but it's also a roadmap for change. What? We name the barriers. So what? We confront the harm. Now what? We choose specific actions that make hospital-to-home transitions safer for older adults, their families, and the teams who care for them.